Good afternoon, ladies and gentlemen. We'll be starting shortly. I'm not sure if you already have at least enough members. Good afternoon and welcome.
Thanks, Toby. So I think you can start.
Perfect. Thank you very much. Good afternoon, ladies and gentlemen. Welcome to our webinar today, to another hematology deep dive session. It's a pleasure for me to be your host for today. I am Dr. Thabiso Rapodile from SANBS. I'm the lead consultant for training, education, and advisory services. So welcome. As you can see that this session is presented in collaboration with South African National Blood Services, and we'll be discussing a crucial topic, ethical considerations in blood transfusion by Dr. Petrolise Wessels. Before we get to the presentation, let's see, I need to move the slide forward. May you please, yes, perfect. Next. Let's do some housekeeping first before we get to the presentation. Some housekeeping notes, yes, the recordings of all the previous ones, including this one, will be on the website for Blood SA under resources, and you go to deep dive. There will be a Q&A session at the end of the session, so please write in the chat box your comments or questions, and we'll get to it as soon as the presenter is finished. We've got a mailing list for any requests or queries. Please contact Melanie. And yes, this is CPD accredited, and you will be receiving your ethics point for this session today, and they'll be automatically submitted directly to HPCSA for all the attendees in South Africa. But you need to attend 1 hour for you to qualify for that CPD point. Okay, Blood SA and the speakers value your honest feedback. So at the end, please complete the anonymous feedback survey immediately as soon as the Zoom meeting ends. Thanks to the ladies that always introduce and put together these wonderful sessions. The management team for Blood SA, from Estelle Ferber, Herdine, Bridget, as well as Nicole. It's always awesome to work with you ladies. And our agenda today is ethical considerations in blood transfusion by Dr. Petrolise Wessels. And let me introduce my friend and colleague who's been with SNBS for about 11 years. Petrolise Wessels is a lead consultant for patient blood management and transfusion medicine in SNBS. She also serves on the Global Transfusion Forum working parties. She's a UFS lecturer, has co-authored the PBM course on short learning program for doctors. And she's also done that for a textbook chapter for AABB, as well as a contributor to the National Maternity Care Guidelines. She holds a BMed Science and MBCHB degree, as well as a postgraduate diploma in transfusion medicine, all from the University of Free State. So internally, she is a very busy lady, responsible for our processing laboratories, supporting them, as well as our blood banks. And yet externally as well, she's supporting patient blood management in South Africa on behalf of SANBS, and drives the best practices in transfusion, as well as hospital support in the different hospitals where SANBS works in. She is one of the co-authors and developers and facilitators of the short learning program in patient blood management, as mentioned before, and she's an affiliated lecturer at University of Free State. She has contributed to the National Maternity Care Guidelines in South Africa on behalf of SNBS, and co-authored that textbook, AABB textbook, the perspectives and practices in global transfusion, specifically the obstetrics chapter, and serves on the AABB Standards Revision Committee, and is contributing to a working party that is doing a literature scoping review on PBM in obstetrics. Okay, I love the last sentence here. Petrolise, this is definitely you. She believes that each patient must have the opportunity to reach their full health potential, and her passion is to drive patient blood management and transfusion drug practices to the rest, and all this rests on that belief. So, ladies and gentlemen, we are in great hands with Petrolise, and we will stop sharing for her to upload her slides. Petrolise, thank you very much for your time. I know you were at another congress earlier this morning, and now you are here with us this afternoon. So thank you very much for being here today.
Thank
Over
you
to you.
very much, Thabiso. And thank you to Blood SA and to the Deep Dive team for inviting me back. If I can just check that you can see my presentation in the right format, Thabiso?
Not yet,
Not
Petrolise.
yet?
Yes,
Why
please
doesn't
share.
want? You know Murphy's
Yes.
Law, it works perfectly when you do the
Yes,
test
it
run.
did.
And
It
then when the
did.
test run is gone, then so
It's
is
there
the,
now.
yeah, no,
It's
perfect. So
there now.
at least we've got it now. Okay, so
Perfect.
let's get started. And thank you very much for Vernon for inviting me back to the HEM Deep Dive. It is one of the things that I truly try to attend each week if I'm not stuck in traffic somewhere. So my day job is best practice and transfusion medicine and driving PBM, and I often end up doing this particular talk. And the reason why I got interested in this is that I was in clinical medicine for 18 years. Then 13 years ago, I joined Sanbus, and much to my surprise, I stumbled on all of this type of information. And it really made me stop in my tracks, because those 18 years in clinical medicine, nobody told me this stuff. And I do think it's important that we tell doctors and nurses this. We owe it to them. So let's get started. So those of you who know me will know that I believe in informed choice. So those who need to leave early, I always start with the summary. So that's the summary of today's talk if you need to pop away for some or other emergency. Just to make it a little bit clearer, because it's a bit hazy now. This little diaper-wearing devil with the very sharp pitchfork, that's the law, and it's a very sharp pitchfork. And our fairy godmother is patient blood management, and her fairy dust truly keeps us out of trouble. Now, in the South African setting, we need to understand that ethics and the law cannot be separated from each other. They are joined at the hip forever and ever. But also in the medical setting, we need to acknowledge that optimal patient outcomes and patient blood management cannot be separated from each other. So let's get started. Why is Sanbus talking about this? And for us, it's very simple. Our purpose is to be trusted to save lives. And our vision is to be recognized as one of the cornerstones of healthcare in South Africa. And unless we're willing to step up and have the difficult discussions and talk about the uncomfortable topics, there is no way that we can live our purpose or reach our vision. So a lot has changed in ethics over the years. And one of the things that has changed is that you have to make the right choices considering all the current circumstances. All the circumstances and the current circumstances. Your knowledge can't be outdated, and you can't consider just what suits you. So transfusion ethics is no longer an isolated thing, and it's not related to the transfusion of blood and blood products. And every doctor and every nurse have a duty bigger than the patient sitting in front of us. And our thinking and our actions, everything we do, should not be about preventing transfusions, doing appropriate transfusions, reducing the numbers of units we transfuse, but it should be directed against the broader public's best interest and making sure that each patient can achieve their full health potentially, a concept that's called health equity. So PB principles are now widely published and they're well known by now, and therefore we can't say anymore, I did not know. It should form part of every patient's evaluation, interaction, and treatment plans. A lot of the headaches are ours, me and Thabiso and our colleagues in Sanbus. So we're just going to talk about the things that rests on your shoulders as prescribing doctors and transfusing nursing practitioners. Let's start with ethics. So Gorski said, ethics is the branch of knowledge that deals with moral principles. And doctors, and very much nurses as well, make no mistake, have the ethical obligation to benefit the patient, avoid or minimize harm. This is a very important concept, and respect the values and preferences of our patients. You all know the 4 principles of bioethics. They've been around for a very long time. It's important to note that one may be in conflict with the other, and that which weighs the heaviest for that current set of circumstances is what must be considered. I urge you, if you run into a situation like this, to always consult, get a second opinion, and document the discussions that you had. And all transfusion-related decisions should be based on these 4 ethical principles. Let's start with autonomy. It's the capacity of a rational, competent individual to make an informed, uncoerced decision. And every single competent adult have the right to decide what will and what will not be done to their bodies. So in transfusion, we're looking at 2 sides of the coin, informed consent and informed refusal. As far as informed consent goes, the requirements is as follows. The patient must be competent to understand what you're telling the patient, and the patient must be able to comprehend the disclosure. Also, the patient must receive full disclosure, and the information must enable the patient to make an informed decision. After that, the patient obviously consents to the proposed intervention or treatment, and this discussion must be documented. Now, for informed refusal, you must respect the patient's values and beliefs. The whole process must still happen, and it must still be documented, and all the signatures must still appear there. The big thing about informed consent and informed refusal is that when I do this talk in person, quite often nurses or doctors would come up to me afterwards and say, you know, we find that during the day when the family and the friends are around, the patient says, I don't want blood. Tonight, when everything calms down and the corridors are empty, I'm being called back and the patient says, you know what, can you do this for me? But before tomorrow morning, I don't want my family to know. So it's important that we acknowledge that as much as we can, without realizing it, coerce a patient into consenting, social pressure can coerce a patient into refusing. And therefore, ensuring confidentiality for your patient is extremely important. Also remember that previously autonomous people who made a decision not to use blood products but are presently incompetent, please make sure that you respect their previously expressed wishes. They stand. So let's talk about beneficence. This is our duty as healthcare workers to act to the benefit of patients, to promote patient welfare, and it's important to understand that beneficent actions can prevent harm and can remove conditions that may cause harm. Now, I love to use this example because it happens in, I think, 80% of hospitals in South Africa. How often have you done a ward round and you walk past the nurse's station and you see the telltale brown paper bag and you know there's a blood product in there, because it's blood products in there. But you keep walking because you don't have a patient that needs a transfusion. That is a condition that may cause harm to a patient. And we have the obligation to remove conditions that may cause harm to patients. So when you see something like that, you must act on it, because that situation that you have seen could potentially harm a patient somewhere later the day. In transfusion, we're looking at the fact that a transfusion must be based on a clinical need, a genuine need. If post-transfusion information becomes available of any possible, potential, or probable harm, the patient must be informed. And here we think immediately of the look-back program, which is not only an ethical obligation, but in South Africa also a legal obligation on all of us. If you get a letter from SANBIS that says your patient might have been exposed to a possible window period unit, then you must assist with the look-back program to trace the patient, to test the patient, that we can assist the patient if required. Information concerning transfusions must always remain confidential, And you're not allowed to limit your patient's options because you did not keep up with knowledge. Patient blood management, I will say this again, have been around for decades now. We cannot say anymore, I did not know. Non-maleficence. This speaks to the fact that as healthcare workers we must do no unnecessary or unreasonable harm, and we mustn't expose patients to an unnecessary risk. It also speaks to the fact that we should not deprive others from the goods of life. So in transfusion, we're back to the fact that there must be a genuine clinical need for every transfusion that you do. You always have to weigh the benefits and the risks, and you have to choose the best course of action for that particular patient in that particular setting, because all hospitals are not created equal and you don't have access to the same things everywhere. You have to make sure that you don't do unnecessary transfusions and that you don't transfuse an unnecessary number of products. If you have inadequate knowledge of the treatment, you are probably going to end up exposing your patient to an unnecessary risk, or may you even cause direct harm. It also speaks to the standard of care, that brown paper bag at the nurse's station, walking through the ward in Uppington in summer where it gets 45 degrees in the hospital easy, and seeing a red cell unit lying on the bedside table waiting to be transfused. Somebody needs to step up, speak up and say, how long has that unit been lying there? What is the total time out of cold chain? And remove that risk from the patient. But it also speaks to the use of the uncross-matched blood in those little emergency fridges. That blood is O positive or O negative. That's all we know about it, and we know all the markers are negative. You've got no idea what your patient and that unit's compatibility is in relation to all the other blood group systems or all the other red cell antigens. It's a risk. Also, if you're looking at elective cases, and you are going to treat a pre-op anemia with a red cell transfusion, just because you do not want to postpone the surgery, that is unethical behavior without a doubt, and you cannot defend that. Let's talk about justice. Now, this speaks to the equitable distribution of benefits and burdens to individuals and social institutions. When there's enough blood in South Africa, like there is now, our team on the collection side and the marketing side, I think they have worked themselves to a standstill over the past couple of weeks, because I don't think I was in Sandwich in this 13 years ever in a period where we had more than 7 days blood stock for this longer period. They really did a remarkable job. So everybody benefits. But the same way, if I start sending out that dreaded cutback letter where I'm telling you we're at 2.8 days stock, we're going to limit your orders, then everybody in the 8 provinces that SANBIS covers is going to be limited on their orders. It also speaks to the fair, equitable, but appropriate treatment of all patients. And in transfusion, it means the following. Whether you are in Joburg, whether you are in Uppington or Lusikisiki, if you bleed, you should at least have access to red cells. Everybody should have access to red cells. So patients should be treated equitably for the same healthcare condition. All your medical decisions relating to transfusion should be based on the best available evidence and the best available treatment, adjusted to your local circumstances. If you don't have a cell saver, then you don't have a cell saver. If you don't have tech, then you can't do that type of goal-directed transfusion to that level. Nobody can fault you. But with all the love in my heart, every hospital have access to tranexamic acid. And it will be very difficult to justify why you don't have items that is generally accepted to be available if you are not using them for your patient. Patients should receive the most appropriate blood products available, and they should only receive those products that are clinically appropriate at the time and will afford the best outcome and the best safety for the patient. Please keep in mind that in times of shortages, it's really difficult to keep the emergency fridges in the far-off rural areas stocked. There's just not enough Group O blood to get it moved out to those far-off places fast enough. So wastage of a scarce resource may really impact negatively on the greater patient population. I want to stop for a minute on a concept called distributive justice. And this is fair, equitable, and appropriate distribution of healthcare resources. All healthcare resources, not just blood products. It speaks to the allocation of scarce resources and the care of uninsured patients. So whether you are in a public hospital or a private hospital, if you need a platelet, everybody should have access to a platelet. There can't be preference to the insured patient in lieu of the uninsured patient. Let's look at some numbers because I love numbers. Those of you who know me will know I spend hours looking at numbers. This is a publication that was done, it was a collaboration between SANBIS and SACIMA, and they looked at the red cell usage patterns in South Africa for a 5-year period. Now on the left-hand side, the dark blue is the public sector graph, and on the right-hand side, the light blue is the private sector graph. Now if you look at the public sector graph, left is male, right is female. If you look at the female profile, it looks like the side view of a pregnant woman, né? And that is exactly where the red cells in the public sector in South Africa is going to, females of childbearing age. However, if you move over to the light blue graph and you look at the private sector, you don't see the same pattern. It's almost a flat line. So that must tell us something. The females in the public sector ends up needing more transfusions. What is the reasons? Is it just the socio-economic status and the general iron status because of the poor diet? Is it because they can't access proper antenatal care, so nobody looks for the anemia, nobody manages the anemia properly during the antenatal, which is months-long period? But it clearly is an indication that we need to go and reinterrogate what happens to our women of childbearing age that is not insured. Something is not right there, and we're seeing the effects of that in the red cell transfusion patterns in South Africa. The same publication, if you look at the 2 columns right on your right, far right is the per capita use in the private sector, and just to the left of it, the per capita use in the public sector. Now in the private sector, the per capita use is between 34 and 38, and it's still climbing. In the public sector, it barely hit 12 one year, and it hovers around 11, and the picture is still currently the same. Again, I have to ask the question, does this mean the private sector doctors waste blood? The answer is no. Doctors in South Africa does not waste blood. If my private sector average transfusion trigger is around 8.47, 8.5, how on earth can we say that they are wasting blood? My problem, I think, in South Africa, and I'm going to ask the questions and not even attempt to answer them, you can go and answer them for yourself, is, first of all, before you order blood, there must be a doctor to order the blood product. No. So the patient in the public sector must be able to access care. They must be able to access a level of care where certain interventions is going to be taking place so that blood products are needed. So if I don't have access to healthcare, I don't have enough nurses, I don't have enough doctors to provide an adequate number of interventions for a big enough number of patients at a specific level, clearly you will not be needing red cells to transfuse. Ne? So this for me is a very harsh, almost indictment against the fact that our patients in the public sector does not have access to care like they should. let's talk about the legal considerations in transfusion medicine. The little guy with the very sharp pitchfork, very happy face, but he's just fooling you. So chapter 2 talks about informed consent. And it's not just informed consent for transfusion, it's all informed consent. And it's very specific that the user, who is the patient, must have full knowledge of what you are going to do with them. And the healthcare provider, which is in this case the doctor prescribing the transfusion, has the duty to inform the user. So the informed consent process must be handled by the treating doctor. You need the consent of the user after you've given adequate information to allow that patient to make an informed decision. We can't choose what we're going to share and what we're not going to share. Also, the patient must be afforded the opportunity to participate in the decision-making process. There are certain circumstances where you can intervene without consent. We'll get there in the next slide. And then section 13 is our legal obligation to keep good clinical records. And this, I think, is where we fall flat on our faces. That dreaded little form that just moved onto this corner of your screen, that is a legal document. And if I get those documents in the condition and the incomplete condition that I do receive them in the blood banks, it's very difficult for me to think that your other medical records will be more complete or better kept. So chapter 2 says a couple of things about informed consent. It must be done by the treating doctor for a specified service, in a language that the patient can understand, at a level of the patient's understanding, not high-level convoluted terminology. Tell them in layman's terms what we're going to do. It must be written or documented, and there must be a witness to consent. The witness is the witness that the process took place uncoerced, voluntarily, and that the patient had time to ask questions and participate. The witness is not responsible for the content of the discussion. Whether or not the doctor discussed all the content that we were supposed to discuss, that rests on the shoulder of the requesting doctor. If there is refusal of treatment, all the steps must still be followed. So what must you tell your patient? You must tell them what you're going to do. You must tell them the benefits versus the risks. And if you, as the prescribing doctor, does not truly know the risks related to transfusion, and for the different risks for different products, how can you actually tell your patient about these risks? Because you could only tell your patient what you know. You have to tell them about the available alternatives, the likelihood of success, and the number of interventions planned. And here I'm thinking about patients in ICU who's going to receive repeated transfusions, mothers who is going home after they discharge, but they sign consent for the prem baby for transfusions before she leaves. There must be a discussion around the number of interventions planned. And that will guide you as to for how long is your consent valid then. The recuperation time and the costs. So in the public sector, we never have the cost discussion with the patient. But I do think we've got the obligation as healthcare workers to have that discussion quietly with ourselves, somewhere either in here or in here, wherever you choose, because we live in a resource-constrained setting. And on the one hand, we must do what is exceptionally good for the patient at all costs, but we also have to think about the cost benefits and cost-effective healthcare. So if one unit is good, why am I going to waste two? If I can rather give a red cell and a FFP early on and therefore prevent having to give 4 red cells down the line, why am I not doing this? You must think about the cost of the treatment of the patient overall. Right. So when are you allowed to administer treatment without the patient's consent? No, because these things happen. First of all, as a patient, I can mandate somebody to act on my behalf, or you can seek consent from the spouse or the partner, the parent, the grandparent, the adult child, the brother or the sister. But as the law stands now, as it's written currently, there seems to be a particular order in that group. Now you can just imagine, I'm from a very conservative Free State farming family. So imagine I have got a partner. We decided, marriage is not for us. Marriage is outdated. My parents doesn't like it to begin with. I'm against blood transfusions. My partner knows this. I'm in a terrible accident. My partner steps up and tells the doctor she wouldn't want a blood transfusion. My parent is going to say, listen, you didn't even care enough about my daughter to marry her in the first place, and now you want to make a decision that's going to kill her. So these are very tricky and very sensitive conversations, especially when there's a strict hierarchy in a specific culture. So handle them with care and just be cognizant of the feelings without losing view of what the law requires from you. Treatment can be authorized in terms of law or by a direct court order. If you think about minors whose parents are refusing treatment. Failure to treat poses a serious risk to public health. If you've got a multi-drug resistant TB case and this patient says, I'm not taking those tablets, I'm going home, you really cannot do that. You cannot allow that to happen because it's a serious risk to the bigger public health. So you are allowed to intervene there. If delay in treatment might result in death or irreversible damage, but, and this is such an important one, the user has not expressed, implied, or by conduct refused that service in the past when they were a mentally competent adult. So just because I was in a car accident and I've got head trauma now does not mean that my original wish, which is visible to you and made known to you to not receive blood products, may be overridden. So let's talk about transfusion. So this is Chapter 8 in Regulation 179. So Chapter 8 used to say only a registered medical practitioner or dentist, I'm not going to elaborate on my feelings of the dentist needing to give me a transfusion, or a person acting under the supervision or instruction may administer blood. Let's stop there. In South Africa, we do not have the luxury of doctors standing next to the bed to supervise while the blood is running in. It's never going to happen. So the nursing staff can act on your instruction to perform this transfusion. And that written instruction is a prescription. So doctors, unless you prescribe the transfusions, I hope you realize that nursing staff are under no obligation to perform those transfusions. Once you have prescribed the transfusion, then it falls within their scope of practice to perform a transfusion. But the last part of the sentence also said prescribe a blood or blood product. And then clearly things went wrong because otherwise Regulation 179 would not have been promulgated in 2012. And Regulation 179 reads, no blood or blood product may be ordered unless it's prescribed by a medical practitioner in writing on a form created by the Blood Transfusion Service. Now those of you, I've noticed one or two Nkosi Albert Lutuli names and a couple of Netcare names. Those of you who are working in Netcare or in Nkosi Albert Lutuli, you are doing electronic ordering. You don't have to worry about that because irrespective of what it looks like on your side, the development of that information that we need to pull through from your side was developed by SANBIS. So that still fits the legal criteria of a form created by a blood service. Regulation 179 also speaks about hemovigilance. And it says that participation in hemovigilance is a legal requirement for all of us. If we touch the chain of transfusion, we've got the legal obligation to participate in hemovigilance. And earlier I showed you that we also have the ethical obligation to make information available to patients if it becomes known. So, hemovigilance systems in South Africa, it is all adverse events, including donor adverse events for us in the blood service, and all look-back cases. So you have to participate All your reactions must be reported. It must be investigated. We need to get that information back to SANBS that we can do the proper testing and write up those reports regularly. So that is the much hated form. Now I'm going to try and explain to you why this form, because whenever I go to a hospital they say, can you please make your form shorter or easier or less complicated? So I can't do that, because the moment I do that, I'm slipping up either on the side of the law or on ethical requirements. So the first thing that you give me is the patient information. Now in South African law, all blood products must be traceable cradle to grave. So I need to know what happened to that blood product, and I must be able to link this blood product to a patient. Otherwise, we're breaking the law. The other thing is this information, and now we speak to Section 13 and the quality of clinical records. Mukwena spelled K-W-E-N and Mukwena spelled K-O-E-N are two different patients on my Meditech system. So today, Mukwena K-W-E-N, I receive a sample for her, I cross-match her, she's a group A, I have compatible blood, and I send it out. Tomorrow, you need another transfusion, and luckily, you fill in the form correctly, and you still spell it with K-W-E-N. And I run my sample through the machine, and lo and behold, today she's a group B. And I stop in my tracks and I realize there is something wrong here. So that affords SANBS the opportunity to get hold of the ward, get hold of the doctor, raise alarm and say either the sample switch happened yesterday or the sample switch happened today, but the same patient can't change groups overnight. You then send us a new sample and we actually protect the patient. But if you did not complete this correctly, if you did not give me the file number, because patients can have the same name, the same surname, we had a case like this 2 weeks back and the only date of birth was different. We need all the unique identifiers and it must be completed correctly every time. Otherwise you are depriving your patient of that additional safety layer and then you are actually causing harm or risk to your patient. Now this is the area where you choose what blood product you're going to give your patient and how much of what blood product. And my question is, do you know which patients must get leukodepleted blood, filtered blood? Do you know which patients must receive single donor apheresis platelets? Do you know how much cryoprecipitate a patient need? Do you know whether your TTP must get cryopoor plasma or FFP? Because if you don't have enough knowledge and you're exposing your patient to the less than best product available, then you are actually harming your patient. This is where you tell me what type of cross-match you want us to do for you. I am well aware that in the private sector, because the nurses get a lot of pressure to not phone the couriers for unnecessary reasons, they are under severe pressure to prove that it's an emergency case before they phone the courier. And what does the poor nursing sister do? She ticks emergency on the form so that it can have the correct amount of gravitas and the driver can actually go and make the trip to the blood bank. However, if you don't understand what that block is for, you're exposing your patient to a whole additional layer of risk. Because a standard cross-match means the unit is fully compatible with your patient. An emergency cross-match means I've done part of the cross-match. I haven't even completed the cross-match by the time I give you the blood. And the part that's not done is the 37-degree part. And what is your patient's body temperature? Your patient's body temperature is not room temperature, 20 degrees. And when you do an emergency cross-match, that's the only part that was done by the time I give you the blood. So please, doctors, are you sure that this is not happening on your behalf if you don't tick this yourself? Because legally, you remain the person responsible for choosing the level of risk to which you expose this patient to. Moving on. the diagnosis. How often does your clinical files get lost in the ward? How are you going to prove 5 years, 7 years, 10 years afterwards? What was the reason why you exposed this patient to the risk? Our forms do not get lost. We were able to trace a form, I think the longest was 23 years backwards. So our forms don't get lost. So if everything gets lost, and God forbid you get invited to a court appearance, and the only document that's there is this form, and the diagnosis is D64.9, or anemia, or chronic anemia, even worse, how are you going to justify why you expose the patient to the risk of foreign human tissue? So I am begging you, treat these forms with the necessary respect. A diagnosis means a proper diagnosis. Why are you exposing the patient to the risk of a transfusion? Put it on paper for me, please. So that is where you sign your name as the requesting doctor. If I cannot get hold of you, and there's a delay in treatment to the patient, the doctor who I could not get hold of is responsible, not the blood service, because the blood service cannot issue a problematic unit. Can be an autoantibody we pick up, it could just be an incompatibility which we don't know why it's incompatible yet. It could be an inconclusive blood group and we need more information on the true diagnosis. But my blood bank staff cannot release a unit that has got an issue with it. And the only way we can resolve that issue is by talking to the doctor who asked us to send the blood. If I cannot speak to the doctor, that unit cannot leave the blood bank, and therefore the patient's treatment is delayed. And that falls on the shoulder of the person causing the delay, and in such a case, it's the doctor who we could not get hold of. Now this is where the doctors sign, and this is a legal document. And right above that is a red block. Now I love asking this question if I'm doing an in-person talk because I find it so entertaining. I say, who filled the form in the last 6 months? And almost all the hands go up. And I say, who read the warning in the last 2 years? And maybe 3 or 4 hands will remain up. So I'm not sure what we must do, because we've made it pink. We've put red letters. We start with warning. You sign right below it. So dear doctors, this is a legal document and this is what you sign your name to. You say you know that blood may transmit diseases. You say that you know who we collect blood from in South Africa, what we test for, and how we test the blood. Because you said by signing your name there that you know this. You also say that you know that in a country with a high disease prevalence, there could be transfusion transmitted infection, although the unit tested negative because of window periods. Then it says the doctor who orders blood must take it in consideration and is responsible for discussing the benefits and the potential risk for the patients, and then obtain informed consent. It also says that all transfusions must be medically justifiable and alternatives must be considered. So please be aware of what you sign your name to. This is even worse. This is the emergency fridge blood form. So keeping in mind when we send this blood out to that little emergency fridge, we've got no clue who's going to receive this blood. Only when you send us the completed form back can we link it to a patient and fulfill that legal obligation of linking it to a patient. Currently, just under 15% of the emergency units across the 8 provinces that SANBA supplies is untraceable. The law is being broken 15% of the time in those 8 provinces. So first of all, let's start. It's uncross-matched blood. It's emergency stock. It tells you this is for life-threatening situations only. I'm asking the doctors who don't have a blood bank on site Do you know how the blood reaches your hospital? Do you know who brings it? How do they bring it to your hospital? How is it tied into the fridge? Is it tied or is it just lying there? And if it's just lying there, how do you know that somebody doesn't take it out? And if the resus was unsuccessful, pop it back in after who knows how many hours. And tomorrow night you are taking the legal risk on your shoulders for exposing the patient to a unit that was out of cold chain yesterday already. These are the questions you should be asking yourself, and you should be very worried about it. So go and interrogate your emergency fridge maintenance and control policies and make sure that you feel it's safe to expose your patients to these units. Again, like I've said, it must be traceable, every single unit. I don't know who's going to receive this unit when I send it out to your emergency fridge. You must let me know retrospectively who you exposed to this unit. Then RH testing. Last year in South Africa, 134 women of childbearing age, whom we at SANBIS have proved that they were RH negative, had to be exposed to RH positive units because there weren't O negative units enough to give these patients, females of childbearing age. It is illegal and ethically unjustifiable to use a resource as scarce as an O-neg red cell in South Africa without making sure that your patient is indeed RH negative before you expose them to an RH negative unit. This is for life-threatening emergencies only. Do you know how many of these forms we get back and the diagnosis is chronic anemia? Just those two words, nothing else. Or D64.9. And that is for uncross-matched blood that you're exposing your patient to. And then again, I call these doctors that I'm going to tell you about now marshmallows. You walk into casualties tomorrow morning, the nurse runs to you and say, "Doctor, last night was hectic. And we had a resus and it was crazy. And we used the emergency fridge blood and doctor went off duty now. But the guy at the blood bank is very unreasonable. He doesn't want to give me a replacement unit without the form being filled when the guy is actually following the law. Please sign the form for me." And this is why you're a marshmallow. Because all you think is you want to help the hospital, you want to help the sister, you want to help the next patient who comes to the door that might need an emergency fridge unit. But if everything gets lost, all your registers, all the patient files, and the SANBIS form is the one thing that didn't get lost, your name and your signature is going to be on this form as the person who made the decision to expose the patient to the risk of uncross-matched blood. Please keep that in mind. So litigation in South Africa is a reality. I just put this in on Google, and a beautiful website popped up. And it tells you that faulty blood transfusions is one of the reasons why you can litigate. It also tells the public that if you think you're a victim of medical negligence, you've got the right to look at your charts and your records because it can help you build a solid case. Then very helpfully, it continues to tell you when you can say it's medical malpractice. If the doctor did not obtain informed consent, not the nurse, the medical practitioner. If the medical practitioner didn't adequately explain the risks involved. If an administrative error or improper testing led to the wrong blood being transfused. If a blood transfusion was given when it wasn't necessary. That's a scary one there. If a blood transfusion was administered improperly, that blood at the nurse's station, lying on the bedside table, the blood in theatre that the tubing is run through a bucket of hot water to heat it up, that is at improper administration. When infected blood was transfused due to improper screening. All of those things constitute medical malpractice. Very helpful website. It also tells you who you can sue. You can sue the doctor who performed or ordered the transfusion, the hospital where the transfusion took place, or the blood donation service that supplied the blood product. It is a reality in South Africa. What is the lictual liability? This is where harm or damage was caused either, pardon me, I've been talking too much today already, was caused either negligently or intentionally. Negligence will be deemed to be present if a reasonable person would have foreseen harm and would have taken steps to avoid such harm, but the person defending the case has obviously failed to take these steps. In the case of an expert or a professional, your conduct will be measured against a group of your peers, a reasonable expert or professional. Now, in the South African situation, if you as the doctors or the hospital followed acknowledged guidelines, you have your policies and procedures in place, all of you who is administering blood is following the procedure or the policy on how to administer the blood product. If we at the blood service keep our accreditation up and we follow all the requirements from SANAS and ISO and so forth, it will be very difficult to say that we were delictually liable. However, criminal liability is a tad more worrisome, and there is two types of charges that can be brought against you. The one is assault and the other one is culpable homicide. So as far as assault goes, that is administering a transfusion without the necessary consent, and as far as culpable homicide goes, that is wrongfully or negligently causing the death of another person. Now, this negligence can either be by blood service or a practitioner. The patient passes away and the individuals involved might be charged or convicted. So everybody who orders blood must be aware of their legal responsibilities regarding to the administration of blood and blood products. And just on the sideline, in South Africa, there were 2 people found guilty of culpable homicide in the past. It was 2 different cases. It's not the same case. One was a medical practitioner and the other one was a blood transfusion medical laboratory technician. So I can't sit here and give you all this terrible news and I don't give you a plan and something that you can go tomorrow and start doing and start looking at and making things safer for your patient but also for yourself. So let's start. You have to transfuse blood only when there is a clear clinical indication, and you have to warn patients of the risks inherent to transfusion and also tell them about the available alternatives. And you have to obtain and document informed consent. Now, doctors, that's the easy part, because you are there. You are in charge of this processes. You are doing this yourself. You must just write down what you've done. That's the easy part. You can keep your eye on it and you can make sure it's done. The next group is a bit tricky because now the doctor moves away from the ward and now the nurse have to take over the transfusion, yet the doctor will also be called to be responsible if things goes wrong. So let's look at the next group. Correctly identifying the patient and the number of units to be transfused, ensuring that appropriate compatibility tests have been done, ticking the emergency block when it's not supposed to be an emergency cross-match, ensuring that blood has been handled prior to and during transfusion in a correct manner, ensuring that blood has not passed its expiry date. There's often units from the emergency fridge that expired that ends up in patients. Terrible, but it happens. And permitting only responsible persons to administer blood. So how do we safeguard the patient against all of this? And the answer is easy, your hospital transfusion policy. So as doctors, you need to go to your hospital tomorrow and say, who can give me a copy of my hospital's policy? And you need to scrutinize that policy and make sure that you are happy that all of the things we talked about today is adequately addressed in that policy and it's described in a way that keeps your patient safe. On the nursing side, you must get hold of the policy and you must make sure that it's written in a way that you actually understand what they want you to do. And if it's not clear for any of the parties, I beg you to speak up that the policy can be improved. So then also you have to make sure that blood is transfused at the proper rate. And that's easy as pie because the doctor must prescribe transfuse the unit of red cells over this period of time. Next group is a bit tricky again. So we're back to going to scrutinize your hospital policies and make sure that you are comfortable with what's in it. You have to observe and monitor the patient before, during, and after the transfusion. You have to effectively manage any reaction, retain blood samples as required for delayed reactions, and report any reactions or death. Please go and scrutinize your hospital policies. If you feel uncomfortable that it's not adequately addressed, speak up. If you feel uncomfortable that it is not written in a way that is very clear on what is expected of you as a registered nurse to do the transfusion, please speak up. Tracing, counseling, and testing recipients of blood transfusions identified through the Look Back program. If you can tick all of those things on those boxes, and this list is in the clinical guidelines that's available on the website, so you can go and find that list there again. If you can tick all of those, I promise you, you will afford your patient the safest and best possible outcome, and it goes without saying that you will also safeguard your careers. So please empower your patient with adequate and appropriate information to allow them to participate in this decision-making process. Always consider the 4 ethical principles and don't limit your patient's options because your knowledge is outdated. Show cognizance of your legal obligations and know your responsibilities regarding a transfusion. And always, always, always apply PBM measures not as a last resort, but right from the first contact with your patient. Screen for and treat anemia properly, always. Thank you very much, and I am happy to take questions.
Thank you very much, Petrolise. That was amazing. I was enjoying that talk quite a lot. Checking the chat box here for any questions. I've posted the attendance register for SNBS since we do need to have the proof that you were here and presented. So I don't see any other questions here on the chat box, but I do have a hand. So thank you very much, Estelle. Please go ahead.
Good afternoon, Tabiso,
Good
and also
afternoon.
Petrolise. I just have a very simple question.
Okay.
I don't think I heard you speak about it, but the time of the time, how long red cells run in, and what is the advice you give? Did I miss
Okay,
that?
no, because that's
it.
yeah,
But,
no, but
it's actually
that's
quite a tricky one because
very, very
there's
difficult,
different
Estelle, because
practices.
you can't have a blanket situation there. And therefore it's very important 2 things, that your clinical notes must indicate the clinical condition of the patient and your prescription must indicate how fast you want the product to go in. Because an actively bleeding patient and a symptomatic chronic anemia patient who is really decompensating and needs a bit of help now, it's not the same transfusion rate. And to try and do a blanket number and say for all patients it must be this, it's going to be a very dangerous practice. So that is where your clinical understanding of the underlying condition of your patient and the impact of the red cell that you transfuse must meet each other and determines the rate of the transfusion. And it's a very good question, Estelle, because that is the reason why the rate of the transfusion must be specified on the prescription.
Yes,
Okay.
but I think my question is specifically for chronic transfusions. I agree that, and it's perhaps something good for us all to remember that indeed, if somebody is bleeding actively, you can, you must transfuse appropriately. But
so you want a chronic one? Okay,
a
so
chronic one. That is
a
quite
chronic
a tricky one in my opinion.
So you know that the South African guidelines say a red cell can only be out of cold chain for 6 hours. There is a little bit of debate from the ISBT group in the world that says no, they actually want the red cell in within 5 hours. They start to be slightly concerned about bacteria in that 5 to 6 hour, that last hour. But if you think about the volume of a red cell, which is 260 mils, if you space it over 5 hours, or whether you space it over 6 hours, I'm still very comfortable with a 5 hour because the patient is not bleeding anything out. The patient has to a certain degree adjusted to his chronic anemia over time, and therefore you have to push that transfusion time as long as you can so that you don't cardiovascularly strain your patient. So I'm quite happy to make that a 5 hour. because I'm aware of the ISBT group that has mentioned their concern with the 6 hours.
Thank you very much, Petrolise, and thanks, Estelle, for that question. So,
Just from my side, I think it often has to be given faster, but it's just simply necessary. But I hear you, and I think also with the one unit rule, the kind of golden rule, a longer transfusion may be more feasible, a longer time. We did give it much faster in many situations of chronic. But I definitely don't want to mislead anybody on this talk. Don't want to give them information that you don't want as general. So, Petrolise, you know, I'll go with what you say, but we do have to give it faster in many situations, but you must know your patient.
Exactly.
yes, know your patient. Thank
Yeah.
you.
And the thing is, Estelle, you know, when you're standing next to a patient's bed, you see things that the textbook don't see, ne? And therefore, I think nothing can replace the doctor next to the bed. That is your best person to make a call on these things.
Or the good nurse, you know,
Oh,
the nurse
yes,
knows the
yes.
patient. I mean, let's be honest, they are the ones who typically have to, but yeah, they must obey us. Our written instructions, they must obey that. That's true. It must be written. I just want to echo what I see flitting past me. Brilliant.
Yes.
You've got such a beautiful way of saying it, Petrolise. Very much enjoyed it.
Yeah, thank you,
Estelle.
Estelle.
Thanks for always joining. I think you can do this talk by now.
Yes. Okay, there's been a hand by Dr. Zivania Chapanduka.
Thank you very much, Chair. It's
Thank
just
you.
a quick point I want to make. I guess the thing is that the figure to remember in all cases is the figure you can't exceed. You know, so and I think Petrolise just mentioned that debate that how long can you keep a blood unit out of storage? And that's critical because there is a lot of things in there. So if we say you don't use a unit that's been lying outside for more than this time, then that affects also the rate of transfusion. You might have to actually
Yes.
make it quicker.
No, thank you
itself.
very much. Thank you. All right, on the chat box, there's another question as well. What is required of clinicians once an emergency blood unit has been used, the administrative wise? Ruth Gopile.
Okay. Ruth, so it comes back to the legal traceability of all units, ne? So you get a blank form attached to that unit in the emergency fridge. So then the doctor who has made the decision to expose the patient to this transfusion must then fill in that form for us and put in the patient's detail, the RH info, sign the form. Make sure that your patient's file indicate the clinical situation. Why did you expose your patient to an uncross-matched unit? Why was it a life-threatening situation? And then make sure that that form gets back to us so that there can be a replacement unit for the fridge. So that is just on the stock maintenance and the legal traceability. However, if you are really thinking about it, have you ever do you know how the blood in your emergency fridge is being managed? Do you know whether it is just lying there? Do you know whether it's tied by the SANBIS cable tie? So a SANBIS cable tie you will never have extras of. If you get one unit, you'll get one cable tie. So if there's a practice of tying the unit into the fridge, if that cable tie is broken, you know somebody removed this unit from the fridge. And you should be worried, where was that unit for how long? So it's the little things around the maintenance and the control of the fridge that us as doctors I never used to worry about the emergency fridge in the district hospital where I worked in. There was blood in and that's all I worried about. But actually I should be worried about how does the blood get there? How do I know what condition the blood gets there? Is it tied? Who is maintaining the stock? Who is making sure that we don't run out of blood over a weekend? So all of those things I think a doctor needs to, and you don't have to take over that function, but read through your policy at least once and see if you're happy that they've covered all the bases. Tabiso, I can't hear you now.
Mute myself. Hi, I was speaking to myself. Thank you very much for covering that one. Thank you, Petrolise. There is another question here. Lots of thank yous, I must say. Very informative talk, eye-opening, and thanks for the excellent talk. Let's see from whom. Oh, from Yaglin Naidu. 2 questions. What would be an appropriate transfusion rate for a patient on dialysis? And the second question is, how much of detail is required when obtaining consent? Do we include the latest statistics, e.g. the risk of specific infections, the risk of TRALI, etc.?
So again, Yagelin is another person who can actually start doing this talk. Ne? Yagelin, thank you for joining
Yes.
again. It's so nice to see the familiar faces. So again, we're back to you cannot make a blanket statement because not all dialysis patients look alike. Although their diagnosis might be similar, they don't look alike. And there is no way that me as a blood banker sitting in this chair in Roodepoort is going to try and prescribe to a doctor standing next to his patient's bed who know that patient and who has known that patient for a while, because a dialysis patient is a chronic patient. I would really urge you to not go for a blanket number, but rather look at the overall condition of your patient. And then the other one was how much detail is required. So personally, I think my question to everybody on the call is, do you know what so South Africa started doing individual NAT testing for HIV, hepatitis B, hepatitis C in 2005. Do you know that since then, how many transmissions happened in South Africa? And are you aware that 1 million plus blood products is being transfused in South Africa every year between Western Cape and Sandhurst together? So I think if you just have a basic idea of that, you can tell your patient, listen, these guys are doing a test on every individual sample that actually looks for the virus specifically. And they transfuse like 1 million products a year in this country. And since they started doing this test, there was like no proven HIV transmissions, and there were like 3 proven hepatitis B transmissions. And I think that will put it for any layman into perspective, because if I have a 0 in 24 million chance for and I know it's underreported, let's just say that out there. This is underreported in South Africa because these diseases are so prevalent that doctors don't necessarily see it as a potential look-back case and never reach out to the blood services. But you can't take responsibility for that. You can tell your patient they are doing a very sensitive test, some of the best testing in the world, and they transfuse about 1 million products a year in this country. And since they started doing it over the past how many years, they saw 3 hepatitis B transmissions and no proven HIV. And if you tell me my odds are 3 in 23 million, it will mean a lot more to me than giving me a lot of statistics. And that's just my opinion on how it could be handled from a practical perspective. And if you want that information, the latest hemovigilance report has just been published again. So you can have a quick read. It's a beautiful report this year again. Maybe have a quick look at that again.
Yes. Thank you very much, Petrolise. That's our hemovigilance report on the website for 2023, put together by the independent committee. Okay, let's
Oh, there's a
see.
very good question about the Jehovah's Witnesses, Tubbs.
Let's see.
How often are Jehovah's Witness patients seen in practice,
There
and
we go.
how have they been a driver to consider ethical and alternative transfusions in South Africa? Jesse, that's a very good
Good one.
question.
Mm.
So you will see that many of the talks Sanbis gives, we share platforms with the Jehovah's Witnesses, because we both have the same message, is to honor the patient's wishes and preferences. And how often, I would not be able to tell you that, because I'm not in clinical medicine. I only see the number of patients that end up getting blood transfusions. So the how often is a very good question, but I can't tell you that. I think the doctors out there on the ground would actually be able to give you a better indication. I think they've always been a driver. They've been a driver since I was a young doctor, and that is 31 years ago. So they've always been a driver. I just think the whole movement of patient-centered and patient wellness, and the holistic approach to patient wellness, it's not just the illness, it's the mental well-being of the patient as well. That drive has grown over the years, and now you've got all these different entities coming together with the same message, and now we start complementing each other's message to the benefit of the patient. So I think it's really a beautiful place where medicine is at the moment, where we and the Jehovah's Witnesses, for instance, share a platform, and we share the same messages. Just honor your patient's wishes. But I don't know how often, I'm sorry.
Thank you very much, Petra. Well answered indeed. We don't have any other questions. Ladies and gentlemen, thank you very much. I think if there are no other questions, remember there's a survey immediately afterwards. We'd really like to hear from you, feedback from you, and everyone else. Please complete the attendance register that was placed on the for SNBS attendance register link. Thank you very much for your time. That was brilliant. Thank you very much, Petrolise. Always a pleasure to listen to you. Always informative. Thank you very much, everyone. You've been amazing. Thank you for attending. Goodbye.
Thanks. Thank you, Teresa.
Thank you, Estelle, for the opportunity as well.
Great to have you. It's
Goodbye.
lovely. Bye.
Thank you. Bye-bye, everyone.